Good day, learners. This time in this video, we're going to talk about drugs for clients with myocardial infarction. Specifically, I'll be focusing on the updates and the pointers. Now, there are certain things that are usually a little bit controversial, especially for test takers. When we are about to take our test, sometimes we get enmeshed with just focusing on the drugs, the classifications, the side effects, that sometimes we forget to cluster the drugs all together, note the interactions with each other, and sometimes we forget to interconnect the relevance of using specific drugs for a specific disorder. So in this video, our goal is to actually familiarize ourselves with the drugs that are usually used in the management of myocardial infarction. I've gotta do, so I'm not crying. So let me begin with a question. Is it appropriate to administer a thrombolytic agent to a patient with myocardial infarction who initially received aspirin? Now, sometimes when a patient is suspected of having myocardial infarction because of chest pain that has lasted more than 20 minutes and is already in an ambulance being taken to the emergency room of a hospital, and then all of a sudden, the patient was actually given aspirin. And when they reached the hospital, the fibrinolytic agents like tissue plasminogen activator, streptokinase are now available. And there are questions that usually pops out of our mind whether it's prudent to administer thrombolytic or fibrinolytic agent to a patient who has already received a blood thinner like aspirin before they even reach the hospital. So this is one question that we're going to answer as we go through our discussion using functional concepts. So reminder, to receive a PDF copy of the essential aspects of this presentation, send us an email at this address, mentor.raygapuz@gmail.com. So we begin with the first functional concept. So treatment goals for a patient with myocardial infarction include, there are three outstanding treatment goals, and the priority would be to dissolve the thrombus. And once the thrombus is dissolved, you would be able to facilitate or reestablish blood flow into the coronary arteries and arterioles. Now, initially, this goal is achieved with the administration of antiplatelets, your aspirin, while the patient is still out of the hospital. And once available, they're given antithrombins like heparin and your fibrinolytic agents like streptokinase and tissue plasminogen activator or TPA as soon as available. Now, the second goal is actually to decrease myocardial oxygen consumption. Sometimes when this sentence is reworded, when this goal is reworded, it becomes a challenge because there are other forms like to decrease myocardial oxygen consumption could actually be reworded as to decrease cardiac metabolism. And sometimes if you don't understand what cardiac metabolism means, then you get confused. Okay? So when you say cardiac metabolism, it's actually the process in which your heart, specifically the cells, convert your oxygen into energy such that it would function normally. Okay, so whether you have a goal that states to decrease myocardial oxygen consumption or to decrease cardiac metabolism, it still means one and the same. And then this goal is actually achieved through the use of beta blockers like atenolol and your angiotensin converting enzyme inhibitors like your captopril. Now, for those who are taking beta blockers, pay particular attention to your patients, especially if they have history of asthma, as your beta blockers may trigger bronchospasm. Also, those who are taking ACE inhibitors, you would notice that they would usually have coughing, and that's usually a side effect of ACE inhibitors. And the third goal of care for the patient with the MI is to manage pain, and this is usually done through the use of narcotics, your morphine. Okay, so the three treatment goals for a patient with myocardial infarction includes to dissolve the thrombus, to decrease myocardial oxygen consumption, and to manage pain. So notice that the priority goal to dissolve the thrombus is initially achieved with the administration of aspirin. And you would note that your aspirin, your antithrombins, and your fibrinolytics, all of these drugs would actually thin the blood. So is it not a disadvantage if the patient is given a combination of blood thinners all at the same time or one after the other? Now remember, the goal of care for this patient is to dissolve the thrombus. And to dissolve it within the first 6 to 12 hours is actually a determining factor on how this patient would survive the condition. So we have to dissolve the thrombus at no cost. So there's no problem having blood thinners altogether because all of these drugs would work in achieving the priority goal, which is to dissolve the thrombus. So to go back to the question, is it appropriate to administer a thrombolytic agent to a patient with myocardial infarction who is initially received aspirin? And the answer definitely is a resounding yes, primarily because the priority goal of care for a patient with the MI is to actually reverse the thrombus and prevent it from further enlarging. And so a combination of blood thinners given to the patient would actually help achieve that goal. So let's move on. Here's another functional concept. Patients with suspected myocardial infarction should be given aspirin in the ambulance or the emergency room. Now, this usually happens while the patient's being transported to the nearest healthcare facility or hospital. Next, patients with symptoms of myocardial ischemia of less than 12 hours, ST segment elevation, or left bundle branch block on the ECG should be started on fibrinolytic therapy. Now, notice this. The patient is only started on fibrinolytic therapy once you have a result on the EKG or the ECG that tells us that indeed the patient is having ST segment elevation, which is characteristic of myocardial infarction. So not unless you have this ECG result, usually your fibrinolytic agents are not administered. Now, what are the contraindications to fibrinolytic therapy? So we have the code BUMP. So bleeding peptic ulcer within 2 months. The most feared concern about fibrinolytic therapy would be bleeding. So that's the number one concern that we need to address. Second, uncontrolled hypertension. This is considered a relative contraindication because if the patient's blood pressure is not that high, then the physician may decide to still administer fibrinolytic agents. Major trauma, including surgery within 1 month, because this could put the patient at risk for bleeding. And puncture of blood vessels that cannot be compressed. Again, this would put the patient at risk for bleeding. Next, a history of ulcer or recent CPR is not an absolute contraindication to fibrinolytic therapy. So in other words, if it's already a history of ulcer. Now, as I do understand, even for females who are menstruating, okay, the presence of their menstrual period is not considered a contraindication to fibrinolytic therapy. Another functional concept, to prevent hypotension, streptokinase is given slowly over a 30 to 60-minute period. So that simply means you have to administer streptokinase slowly. Okay, streptokinase actually reverses clot formation. So it helps us achieve the dissolution of the thrombus and then eventually facilitating now circulation in the coronary arteries and arterioles, okay? Next functional concept, streptokinase is used only once per patient due to its potential to cause allergy and the resulting production of antibodies. Now, streptokinase is actually produced from streptococci. So since it is produced from streptococci, it has the potential to trigger the production of antibodies and eventually may no longer prove effective if it's used for the second time. So usually after administration of streptokinase, if the patient will have reinfarction, they administer tissue plasminogen activator in lieu of the streptokinase. Now, tissue plasminogen activator may cause bleeding and should be used with caution for patients with risk for stroke, the elderly, and those with high blood pressure. Now, since tissue plasminogen activator, which is a fibrinolytic agent, which reverses clot formation, may potentially cause bleeding. We have to assess, therefore, the patient for history, for example, of hemorrhagic stroke, which may potentially contraindicate the use of your TPA, especially when you have an elderly patient. Next functional concept, heparin is used with streptokinase in patients with myocardial infarction, once again, to reverse clot formation. Now, your angiotensin-converting enzyme inhibitors are usually given in patients with large infarcts, And beta blockers are given to patients with myocardial infarction if the heart rate is at least 50 beats per minute and the systolic blood pressure is above 100 millimeters mercury. Now, the primary purpose of your beta blockers is that it slows down the heart rate and actually facilitates maintenance of a normal blood pressure in the patient with MI, therefore preventing potential complications. That's why it's very important that the minimum heart rate as well as the minimum systolic blood pressure is met before a beta blocker is given to the patient. Next, routine use of calcium channel blockers and magnesium have not been proven beneficial in clients with myocardial infarction. Now, this is the reason why between calcium channel blockers and beta blockers, it's usually calcium channel blockers that are not preferred over your beta blockers. So your beta blockers are preferred over your calcium channel blockers. Now, what do your calcium channel blockers do? Actually, calcium channel blockers prevents the entry of calcium into the cells of the heart and the blood vessels, thereby preventing constriction. So in essence, your calcium channel blocker leads to vasodilatation. So sometimes your calcium channel blockers are referred to as your calcium antagonist. Okay, example could be amlodipine, verapamil, diltiazem. Now, these medications are very good at lowering the blood pressure, and some of them would also lower the heart rate. However, there's a potential problem with the use of calcium channel blockers, as it could also trigger palpitation. That could be the reason why your calcium channel blockers are not that preferred in the management of patients with myocardial infarction. Now, one thing that you have to remember about calcium channel blockers when you are taking your test is to avoid giving it with your grapefruit juice. Why? Your grapefruit juice could actually alter the heart rate and the blood pressure and may worsen the adverse effects of your calcium channel blockers. So once again, between calcium channel blockers and beta blockers, it's your beta blockers that are found to be beneficial for clients with MI. We're not saying that your calcium channel blockers does not help decrease the blood pressure or the heart rate. What we're saying is that it is not as beneficial as your beta blockers in the management of myocardial infarction. So if you have an item that goes for select all that apply, and then the question says, which of the following drugs may prove beneficial in clients with MI, then you can confidently eliminate your calcium channel blockers. Like you can eliminate your amlodipine, verapamil, and diltiazem. Okay, although diltiazem is the only calcium channel blocker that has been proven beneficial in the reduction of reinfarction. Now, when we talk of reinfarction, this is going to be after an initial heart attack. If you want to prevent future heart attacks, then that's when diltiazem could be proven beneficial. Okay, so it is helpful in the reduction of reinfarction or recurrent ischemia in non-Q wave infarctions with no congestive heart failure. So this is specifically for non-Q wave infarctions and for patients with no congestive heart failure. Okay. Now, here's another functional concept. Some drugs that may potentially worsen existing cardiac problems include your tricyclic antidepressants like your amitriptyline or nortriptyline. Why? Your tricyclic antidepressants could actually cause palpitation, and that's the reason why you have to check the client's EKG or ECG before tricyclic antidepressants are given as a form of treatment for depression. So levothyroxine, which is a thyroid drug, is also not appropriate. Why? It has a potential to cause palpitation. And finally, furosemide, okay, which eventually could lead to potassium imbalance or hypokalemia, and that increases the risk for the patient to have palpitation. So these medications are usually not beneficial and may potentially worsen the client's myocardial infarction. Okay. So remember, diuretics are usually prohibited in patients with acute right ventricular myocardial infarction. Okay. Now, let's remember that if your patient have an MI and then you are presented with several drugs, you have a select all that apply type of question, and then you've seen a couple of diuretics, you can confidently eliminate it because our functional concept says diuretics are usually prohibited in patients with acute right ventricular myocardial infarction. So they're not beneficial for the patient. Okay, so let's try answering sample questions. Okay, a client with chest pain that has lasted more than an hour has been admitted. Upon evaluation of the patient's medication history, the nurse notes polypharmacy. Now, when we say polypharmacy, it's the existence of a condition in which there's a need for 5 or more drug treatment at the same time. So when a patient's taking 5 or more drugs, then polypharmacy exists. Okay, so which of the following drugs could have worsened the patient's condition? Okay, now what the question is asking you is a reverse of the drugs that could decrease the symptoms of the patient. In this case, the question is asking about the drugs that could have worsened. So in other words, we're supposed to be looking for the drugs that may prove harmful and not beneficial to the patient, okay? So we put an X to morphine because morphine is one of those drugs that can help us achieve the third goal in the management of clients with MI, that is to actually decrease pain. Furosemide is a diuretic and may actually worsen the patient's condition. Levothyroxine is a thyroid agent, so therefore it may also worsen the patient's condition. Aspirin is actually the first drug that is given to the patient before they reach the hospital, especially if they're already showing symptoms of ischemia like chest pain that's already more than 20 minutes. So it's not harmful. So we're supposed to be looking for the medications that could have worsened the patient's condition and are therefore considered as harmful. So aspirin is not one of those medications. And then amitriptyline, which is a tricyclic antidepressant, it may cause palpitation and may therefore potentially worsen the patient's condition, so we put a check. And streptokinase, which is a fibrinolytic agent, the drug that dissolves the clot, therefore this helps in a patient with myocardial infarction, and so we put an X. Okay, so the answers are the drugs that could have worsened the patient conditions. You have furosemide, levothyroxine, and amitriptyline. Okay, so it's shout out time once again. Congratulations to, okay, Michelle Arabaja Tumaneng from Puerto Princesa, Palawan, who just recently passed her test last June 2, 2020, and she's now in Georgia, USA. So congratulations, Sheila, and our pleasure to be of help to you. Okay. So let's learn together. For more instructional videos, subscribe to our YouTube channel, Gapuz Mentors, and my Facebook page, Mentor Ray. So thank you very much for joining us with these updates. Learn more, subscribe to our channel, ask your friends to join us, and let's learn together. Okay? I just hope you like our background. It's new. Okay. See you next video.